Dear students, we are discussing pleural effusion. In the last class, we have discussed the formation regarding the formation of pleural fluid, then the classification of pleural effusion based on the nature of fluid. So today we can discuss the symptomatology, signs, and complications of pleural effusion. First of all, regarding the onset of pleural effusion, the onset can be acute, subacute, or insidious. Can be subacute, acute, or subacute. Then pain is present in the early stages or in the first phase. In the first phase of inflammation, that is during the phase of pleurisy. In the phase of pleurisy, there can be pain. Once effusion is there, or once effusion sets in, pain gradually disappear. Then another symptom you get is dyspnea, and the dyspnea can be progressive also, depending upon the accumulation of pleural fluid. The pressure inside the pleura, or the fluid inside the pleura, exert pressure over the lungs, and the lungs gets compressed. And the pressure is very high, it gradually lead to atelectasis or collapse of the lung also. And the density of the lungs also gradually increase due to this compression. There can be occasional cough also. Cough is usually dry and there is loss of weight. And symptoms of toxemia may be there. Symptoms of toxemia, and this include malaise, fever, anorexia, etc. Then we can detect pleural fluid during physical examination if the fluid is about 500 ml, and if the fluid is very little or the excess amount of fluid is very less, it is difficult to detect pleural effusion on physical examination. That is, we need around 500 ml of extra fluid in the pleural cavity to get a finding during physical examination. But we can detect effusion even if the volume is 300 ml in X-ray. So we can detect pleural effusion earlier in X-ray, but it is difficult to detect effusion if it is less than 500 milliliter. Then passing on to the signs of pleural effusion, there are different signs you get in pleural effusion. I will discuss each in detail. First of all, on inspection. With large effusion, if the effusion is very large, you will get a sign called orthopnea. Orthopnea is dyspnea on lying down. That is, breathing difficulty on lying down. That is orthopnea. That's an important finding in large effusion, dyspnea on lying down. Then preference to lie on the affected side or same side. If the right side is affected, patient prefer to lie on the right side. That is, preference to lie on the affected side or same side. That's also that's also a finding you get in pleural effusion. Then regarding the movement, diminished movement of the affected side. Whatever the pathology, lung pathology, the affected side moved less. So here also, if the right side of lung or pleura is involved, the right side of chest moves less when compared to left side. Then bulging of intercostal space on affected side if there is large effusion in a thin person. If the person is very thin, and if there is large effusion, there can be bulging of intercostal area. Then fullness of hypochondrium. Fullness of hypochondrium if there is large effusion. That is another finding. Fullness of hypochondrium. Then regarding the apex bit, examination of apex bit, there is displacement of apex bit towards the opposite side. In case of right-sided pleural effusion, the heart or the mediastinal structures will be pushed towards the opposite side or the left side. So the mediastinal structures will be shifted towards the sound side or shifted away from the side of pathology. So there can be two type of mediastinal shift, shifting towards the pathology and shifting away from the pathology. In case of lung collapse, the mediastinal structures of trachea will move towards the side of collapse or south side of pathology. But in case of pneumothorax or pleural effusion or some mass lesions, the mediastinal structures of trachea will be shifted away from the side of pathology. That is contralateral shift. And moving towards the pathology is called ipsilateral shift. So there can be two types of shift, ipsilateral and contralateral shift. In case of pneumothorax or pleural effusion, the mediastinal structures is moving away from the side of pathology, that is contralateral shift. So apex beat is displaced towards the opposite side. Then there is a sign called trail sign or sternomastoid sign. Trail sign or trail sign. There is a sign called trail sign or sternomastoid sign. That is very important. It is usually asked in examinations. The sign is the sternomastoid muscle on the side of mediastinal displacement may be prominent. That's a sign. The sternomastoid muscle on the side of mediastinal displacement may be prominent. Suppose there is right side pleural effusion, the mediastinal structures will be displaced towards the left side. So the sternocleidomastoid or sternomastoid muscle on the side of displacement will be prominent. That is called trail sign or sternomastoid sign. Then on palpation there is immobility of chest. Then tracheal displacement, you can palpate trachea. There is tracheal displacement towards the opposite side. Then diminished or absent tactile vocal parameters, Then on percussion, there is a definite finding in pleural effusion, that is dullness. It's called absolute dullness or stony dullness. It's the extreme dullness you get in percussion. That is absolute dullness or stony dullness. And when we note the level of fluid during percussion, that is when we examine from the spine around towards the sternal region, and we mark the upper level of dullness, we will get a tracing called Ellis S-shaped curve. It's called Ellis S-shaped curve. Dullness arising from the spine, highest in the posterior axilla and falling again towards the sternum. And if we join the upper points, we'll get a tracing, or we'll get a S-shaped tracing. That's called Ellis S-shaped curve. Then another sign is we'll get a triangular area of dullness against the vertebral column at the base of the opposite lung or the unaffected lung. That is called Groucho's triangle. Triangular area of dullness against the vertebral column at the base of the opposite lung. That is called Groucho's triangle. That is called Groucho's triangle. So triangular area of dullness against the vertebral column at the base of the opposite lung. Then the Traube space, there is a space called Traube space. The space called Traube space, Traube apostrophe S, Traube space. This is the area overlying the gas bubble of the stomach. This is the area overlying the gas bubble of the stomach, and this is obliterated in left-sided pleural effusion. In case of left-sided pleural effusion, the Traube space is obliterated. That is the space above the gas bubble of the stomach, Traube space. Then in auscultation also there are certain findings, that is diminished or absent breath sounds. Diminished or absent breath sounds. Because of effusion, the sound may not be able to penetrate the chest wall and reach the hands, or the palpating hands, or even the steth. So naturally there will be diminished or absent breath sounds in auscultation. In early stages we'll get bronchial breathing also. Bronchial breathing, because the lung is compressed and the bronchi remains patent also. The bronchi remains patent in the initial phases and the lung gets compressed, leading to bronchial breathing. Then diminished or absent vocal resonance is another finding. Then egophony or whispering pectoral occhi. You might have studied in physical examination. Egophony. Egophony is the nasal tone to the vocal resonance. Then whispering pectoral occhi is the extension of vocal resonance. Egophony and whispering pectoral occhi above the fluid level. Fluid level is seen in pleural effusion. Egophony and whispering pectoral occhi. Then no foreign sound with large collection. If there is large collection of fluid that is up to clavicle level, will get won't get any added sounds, or won't get any foreign sounds in auscultation. That's called silent. Even silent chest won't get any added sounds in large effusion. There can be rales also. Rales in the base of the opposite lung due to lung congestion. That is the normal lung. You can get rales in the basal area of the normal lung due to congestion, lung congestion. Then hard sounds may be obscured in large left-sided effusion. In the case of large left effusion, the hard sounds may be masked or obscured. That's also an important finding in left-sided pleural effusion. So that's about the symptoms and signs in pleural effusion. There are numerous symptoms and signs in pleural effusion. Then we can move on to the complications of pleural effusion. The important complication is respiratory embarrassment itself. Respiratory embarrassment. In case of massive bilateral effusion, the condition may be fatal. Condition may be fatal due to respiratory failure. Then secondary infection of pleural fluid is another finding. Secondary leading to empyema, or which convert the serous effusion into empyema. Then organization of fibrin from the fluid on the surface of collapsed lung, that is called, or the settlement of fibrinous material over the lung tissue, that is called cortication. The process is called cortication. It's called cortication. Settlement or organization of fibrin from fluid on the surface of collapsed lung. And this prevents re-expansion. This cortication prevents re-expansion of lung during the treatment process. Then there can be fibrosis of pleura also. Fibrosis of pleura and obliteration of pleural space. That is called fibrothorax. Fibrothorax, obliteration of pleura and pleural space. And usually happens if pleural effusion lasts for a long time. Then spread of disease to pleura, disease to pericardium or peritoneum also happens in pleural effusion. Spread into pericardium and peritoneum. Then another complication is pulmonary edema itself. Then thrombus of veins, example, superior vena cava, inferior vena cava, iliac vein, femoral vein. In all these veins, there can be thrombosis. Then sudden death can also happen. Sudden death can happen due to pulmonary embolism. So these are the common complications of pleural effusion. So in the next class, we can move on to the investigations and differential diagnosis and management of pleural effusion. Thank you.